Okay, you guys ready to start? Okay, so one thing first, vascular function curves and cardiac function curves. It's a very hard concept. Every year I struggle even getting that across to the students. So don't stress out about the cardiac and vascular function curves for now. The important thing is this, with central venous pressure, it resembles right atrial pressure. We kind of use them synonymously together. The number I want you to remember is 5. That's the number, 5 right atrial pressure or central venous pressure of 5 millimeters of mercury. That's where we want to be at all times. If you're at 2 milligrams of mercury, CVP is low. What do you have to do to get that back up again? You have to give them volume of fluids. You have to give them something to bring that pressure back up again. Low pressure means low volume. So we need more, so you have to give them fluids. If central venous pressure is like 10 or 15, that means we have too much volume, too much pressure in the system. We have to diurese them, like we just learned about, to get that volume off and the pressure comes back down. That's going to be the basis of that question on your exam. I'll tell you right now. There is a twist to it. I'm not going to tell you the twist, but there's a twist to it. So I'll tell you half of the question right now. Either you're going to diurese the patient or you're going to give them fluids. The twist is the second part of that question, which you'll see Friday. My little present to you guys. Sorry. So again, remember 5. If it's lower than 5, you got to give them fluids. Higher than 5, you got to diurese them and get them back to 5. So 5 is the magic number where you want to be at.
5 millimeters.
Yes. That was for vascular and cardiac. Okay, guys, first question. And you should have everything on the Kahoot as well. Okay, what cells are responsible for homeostasis? Is everything showing up? All the answers too? Okay, good. Okay, hemostasis. What cells are responsible for hemostasis? Sorry, not hemo. I even told you that the first day. Don't confuse homeo and hemo. Or first day of this unit.
What do you say for the exam?
It's paused. Is Wi-Fi down or something? They kicked out? Yeah, I froze. Okay. I'm frozen too. I don't know why. Okay, sorry. Okay, so don't follow what I just did. I read it too fast and I said homeo instead of hemo. Okay, so remember, hemostasis. What's the cell for hemostasis? Okay, we're almost all in. Okay, what cells are responsible for hemostasis? What's the precursor to these cells called? Megakaryocytes, platelets. That's involved in hemostasis, stopping blood from bleeding out everywhere. All the following cells are derived from the common myeloid progenitors except which one? Which one is the lymphoid? Lymphoids are what two cell types? B and T lymphocytes. So your B cells make which ones? Plasma cells. Okay, another thing, guys. On my exams or quizzes, if I've never mentioned a word before, chances are I needed a fourth option and I thought of something. So I've never mentioned osteoclasts. Not once. What? But I mentioned osteoclasts or osteoblasts. So on your exam, if there's a weird word that I've never mentioned before, chances are it's not the answer. Okay, which of the following hormones are responsible for creating white blood cells? So, let's go to test-taking strategies. Even if you don't know the answer, go to your medical terminology. Erythro, what does that mean? Red. Thrombo, platelets, and then leuco is your white blood cells. So rely on your med terms. Okay, which of the following blood types will have anti-B antibodies? Just anti-B antibodies floating around. Type A. Type A has the A antigen, but the anti-B antibodies in the blood. What's the last step in hemostasis? What do all clots have to do at the end? Break down, disintegrate, go away. Okay? The final step, you have to break up the clot. What's the second phase of platelet function? They're all A's, so get a mnemonic to remember it, but. Okay. Okay, what test would a good indicator of aspirin function be? What test do you want to order for aspirin? What is aspirin going to affect? Platelet function. It's just platelets. That's all aspirin affects. So there's one test to do with platelet function. That's your bleeding time. Your PT-INR. What drugs affect your PT-INR? Warfarin, Coumadin. What intrinsic or extrinsic pathways? Extrinsic. Very good. PTT. What drug are we looking at? Heparin. What pathway? Intrinsic. Very good. Reticulocyte count, what does that tell us? It tells us new blood cells, red blood cells being formed. They're immature red blood cells. What would be a reason to have a higher reticulocyte count? Sickle cell, severe anemia. You need more red blood cells made to make more trucks, to deliver more oxygen. We're going to have to make a lot more reticulocytes to get more red blood cells. Which of the following is correct with regards to flow? So now we're moving on to the cardiac stuff. Is flow proportional to pressure and resistance? Proportional to pressure but inverse resistance? Inverse proportion to pressure and resistance? Or is it proportional to resistance and inverse to pressure? Does flow go up with greater resistance or go down with resistance? Does flow go up with pressure gradients or reduced? Very good. Cardiac output or flow, proportional to pressure, inverse to resistance. And what is it about the resistance that has the greatest impact? Radius. What are the other two variables? Length of the tube, viscosity of the blood. How is calcium put back into this sarcoplasmic reticulum? Talking about the SR, not out of the cell. Into the SR. Which one goes back into the SR? Calcium ATPase pump. The sodium calcium exchanger, where does that put calcium? Out of the cell. And the sodium potassium pump just keeps those sodium gradients going. That allows for the sodium calcium exchanger to happen, and so on and so forth. What describes the action potential of the SA node? This is an autorhythmic cell, not a muscle cell. The autorhythmic ones. Fast depolarization rate and a fast action potential. Fast dipole rate, slow action potential, slow dipole, fast action potential, or slow depolarization rate. Okay, so let's talk about this. These are autorhythmic cells. The SA node has a fast depolarization rate. And what's the normal depolarization rate of the SA node? About 100. 80 to 100 is your SA node depolarization rate. It's faster than every depolarization rate in the heart. That's why it controls the heart. It's called the pacemaker cells. They control the rate. We're talking about the action potential is how fast does it get to all or nothing principle. Remember, with the autorhythmic cells, there was that sine wave, but they occurred very fast, but the slow amplitude. Whereas the myocytes, the ventricular muscle cells, when they hit action potential, it was a straight line up. That means it got to peak very, very fast. So ventricular muscle cells are the opposite. Slower rate of depolarization, but a faster action potential. What is the rate of the ventricular myocytes if I cut off all innervation to the heart, got rid of the AV node? What would the ventricles be at by themselves? 20 to 40. Very, very, very low. Slow depolarization rate, but a fast action potential in the myocytes. Your autorhythmic cells, SA node, AV node. Faster rate of depolarization, but a slower time to get to your peak action potential. Those are some thinking questions. Okay, so what EKG wave is represented by ventricular repolarization? Ventricular repolarization. Okay, what's the P wave? Atrial depolarization. What is the QRS complex? Get kicked out again? Everyone get kicked out too? I wish there was a way to save this too, because I'm out too. Okay. Is it the internet? Because we're all losing connection, right?
It says we're trying though. So
We trying? Okay, so I'll
it
wait.
says please do not refresh this page. So that's what it says.
Okay.
So it's retrying.
Okay, I'll leave it. Okay, so T wave is the repolarization of the ventricles. QRS complex, ventricular depolarization. The U wave, have we ever mentioned a U wave? You guys may have learned it, but no, it can't be an answer. U wave comes out usually with like severe hypothermia. You'll see a U wave. It comes out, obviously, guess where it comes after? The T wave, yes. They just continue the letters, so a U wave is an addition to the T wave. Where does atrial repolarization occur? It's embedded in the QRS. You don't see it, so we just kind of ignore it. We know what happens, but anyone else reconnect? No. Okay, so we're on question 18, so I'm just going to skip ahead. I'll restart. Oh, 11. Oh, yeah, I'm sorry. 11, yeah, you're right. Okay. Yeah, nothing's working. So we'll restart. Sorry, guys. We'll start at 11.
We'll try to find a way to slow down later.
So, while you guys are logging in, as an example for that Wiggers diagram, I may say, what phase of the cardiac cycle do you see the T wave occurring? Where does that happen? T wave occurs at the very end of systole. Right at the end, you'll see it. What else could be there? What sound is occurring when AV valves close, atrioventricular valves close? Yeah. What else could be there? I can't remember, but okay, let's get going. I'm going to skip these. I don't care about your points. If it kicks me out again, I'll try my laptop. No. Get faster. Not quiz. Gotta get out of here on time. I'm gonna be here all day. Okay, we'll start here. Everyone can join in on here. Okay, so ventricular repolarization is the T wave, yes.
I know, I was like, oh no. Oh no.
Okay, next question. What electrical activity directly comes before ventricular relaxation? Remember, excitation, contraction, coupling. Ventricular repolarization happens right before ventricular relaxation. The QRS complex happens right before ventricular contraction. The P wave happens right before, froze again. Okay. I know. Look at the Wiggers diagram. Look where the P wave is. Go up and see what phase that occurs in. It doesn't occur during atrial systole. It occurs right before atrial systole. That's why half of that P wave was on the first half of that Wiggers diagram. T wave. Okay, what heart sound is with the atrioventricular AV valves closing?
I know, I did the same. I was like, I know,
Okay. S1 is your AV valves closing. Don't confuse that with aortic valve. Okay, what happens at the end of isovolumic relaxation? Mitral valve opens, it closes, aortic valve opens, and aortic valve closes. At the end of isovolumic relaxation. What's happening to the pressure in the ventricle during relaxation? It's dropping. What's the goal to get below what? Atrial pressure. Once it gets below atrial pressure, what door opens up? Mitral valve opens. Remember, just changing pressures during. Now, if this was isovolumic contraction, what happens at the end of isovolumic contraction? What would the answer be here? Aortic valve opens. That's at the end of isovolumic contraction. Okay. Which of the following is a way to decrease stroke volume? Which of those things are going to increase or decrease stroke volume? Okay, if I increase the preload, what will that do to stroke volume? Increase it. If I increase contractility, the heart's going to squeeze harder. Stroke volume goes up. If I increase the afterload, decrease stroke volume. And why is that happening? Less time for isovolumic contraction. Less time for ejection. We're spending too much time in isovolumic contraction, building up the pressure to overcome the afterload. And then decrease TPR, what will that do to your afterload? Decrease the afterload, which will then increase your stroke volume. Okay, what's the site of greatest resistance developed? Where is it?
oh yeah, I said it.
Make sure Danny gets it.
I know, that's what I just.
Yep, arterial, very good, guys. Which of the following is a correct determinant of your diastolic blood pressure? If you increase vascular resistance, you're going to increase your diastolic blood pressure. Faster the heart rate, the lower the diastolic blood pressure. High vasoconstriction decreases your diastolic blood pressure, and a slow heart rate will increase your diastolic blood pressure. Okay, so increase vascular resistance. What's going to happen to your normal pressure if you increase the resistance of the vessels? They're both going to go up. Systolic and diastolic are going to go up, both of them, when you have vasoconstriction going on. Faster the heart rate, the higher the diastolic blood pressure. More volume is in the system, more pressure because you're exercising. Your cardiac output is going up. They all have to go up as well. High vasoconstriction decreases diastolic blood pressure just for the opposite reason we discussed above. And then slow heart rate will decrease the diastolic blood pressure, just the opposite of the faster heart rates. Okay, which of the following scenarios is correct regarding venous return? High rate atrial pressure will increase venous return. High total peripheral resistance will increase venous return. Low blood volume will decrease venous return. Low TPR will also lower venous return. Does high right atrial pressure increase venous return? No, it lowers it. Lowers the pressure gradient. Low blood volume will decrease your venous return. Okay, what's the effect of norepinephrine on your alpha receptors? First of all, alpha receptors, where are they located? In the periphery. Where are your beta receptors for norepinephrine located? Heart. So you know if the betas are only in the heart, the alphas in the periphery in the vasculature, you're only left with two answers because we know it can't do anything with contractility because that's beta. Increased heart rate is beta as well. Alpha receptors increase vasoconstriction. Now, vasodilation in the muscle beds. What is responsible for that? Epinephrine. Epinephrine does that with the skeletal muscle beds. Norepinephrine constricts them. We're shunting blood away. Think of what we just learned yesterday with the renal system. Those afferent arterioles going into the glomerulus. They're under the influence of norepinephrine. Why? Because during exercise, fight or flight, we don't want all that blood to go to the kidneys. We want to shunt it to our muscles. So the vasoconstriction of the norepinephrine shunts blood away from areas we don't need. The epinephrine, which is also released in fight or flight, hits the skeletal muscle bed vascularity, opens them up, and that's that green one. That's the influence of epinephrine. Okay? So there's that one slide that talks about all those different receptors and what they do. Low protein in the plasma will cause what condition? Low protein in the plasma. What pressure are we talking about? What type of pressure is exerted by proteins? Oncotic pressure, at the push or the suck? The suck. So if you don't have a high oncotic pressure because you have low proteins, where's that fluid going to go? Increased edema formation. We have less suck now. The forces that oppose filtration are weak. Our oncotic pressure is low. So we're going to lose the fluid and cause edema to form. Okay, the amount of maximal air inhaled above a regular breath. So while we're on this topic, I think I gave you a wrong word on the spirometries. All capacities are volumes added together. So with this one, I'll talk about it when we get to the answer and explain it. Okay. Inspiratory reserve volume and inspiratory capacity. The inspiratory capacity is the IRV plus the tidal volume. So capacities are two volumes added together. For the inspiratory capacity, It's IRV plus the tidal volume. That's how much air you can inhale maximally. Tidal volume is just your normal air in and out as you're breathing normally. Your vital capacity is all air that is exchanged that you can perfuse, essentially, which is your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. All three together is your vital capacity. We have a little bit of air left over in the lungs with every breath as well. What's that called? Residual volume. If you exhale all the air out of your lungs as much as you can, there's still air left in the lungs. That's your residual volume. If you take residual volume plus your vital capacity, that gives you your total lung capacity. All the amount of air you can get in and out with residual volume. So I will repost that later today on your modules, but it's also in the real drawings that's there as well for all the different values. Okay, what's the most important muscle for expiration at rest?
Isn't it abdominal? Isn't it the abdomen?
That's with exercise. Guys, expiration is passive at rest. It's just your normal chest recoil. With exercise, what muscles are involved? Abdominals and internal intercostal muscles. That is needed for expiration with activity, with exercise. Remember, that's why you get side splints. They're not used to working that much. They don't like to. So with expiration, it's active with exercise, but expiration is passive at rest. No muscles are needed for expiration at rest. Okay, so you're sleeping. What part of the brain controls your breathing? Okay, the cortex. What would I have to say? Voluntary. So if I say you're doing your physical exam on a patient, you're checking for intubation, you tell you're breathing, you're checking the patient breathing in and out. Obviously you can't do it when they're intubated, but when you're doing your normal pulmonary exam, breathe in deep and out, your cortex is telling your diaphragm to do that for you. But when you're sleeping, it's all involuntary and the brainstem takes over. Cerebellum. Whenever you see the word cerebellum, what things should you think of? Balance, coordinated movements. Those are the things that deal with the cerebellum.